I shall now be explaining regarding ulcerative colitis. To understand the manifestations, please look at this crude diagram that I'm highlighting before you. I've shown in the mucosa, the submucosa, the blood vessels of the GI tract, which if damaged will cause hematochezia. Then I've also tried to represent muscularis mucosa. I've highlighted muscularis externa, the muscles part, then the matrix plexus, and finally the serosa. Now what happens in this condition is once again development of aphthous ulceration, but what I'm trying to do in this diagram is I'm trying to show that these aphthous ulcers that are developing will be contiguous one after the other, unlike in Crohn's where there were some normal areas and then an ulcer. In this case I'm not shown any normal area in between, it's just gonna be contiguous ulceration. Now, when these ulcers will develop, most of these ulcers are relatively slowly growing. So let's look at an interesting observation that is seen once these ulcers progress slowly. You see the epithelium that is adjacent to the ulcer. This will try to regenerate. What I've now tried to highlight before you is that in ulcerative colitis, there can be a regenerative epithelium present adjacent to where the ulcer is present. And this regenerative epithelium, when will develop, it will result in this very peculiar presentation, which is also taught in histopath and is called as pseudopolyps. Well, why do they call it pseudopolyps? Is primarily that you see, polyp is gonna be having both epithelium and connective tissue, but here it is mainly the regenerative epithelium adjacent to the ulcer which is causing problems. Below this, there can also be submucosal fibrosis. So remember, stricture formation can be seen with both of them, but the ulcers in this particular case are not gonna go very deep. There is a possibility that these ulcers can go and damage the blood vessels. In fact, most of these ulcers here are gonna travel horizontally and there's not gonna be any full thickness involvement. Because of damage to blood vessels, obviously the hematochezia component would come in. But the point is, unlike when I was describing Crohn's disease to you, where I was showing the ulcer is so deep that it is having a full thickness involvement, serosa is damaged, there is pus production, there is intra-abdominal abscess formation, there is adhesion, there is a fistula formation. None are gonna be seen in this case. This disease always has a partial thickness involvement. This disease always has a pancolitis. Now, when I say pancolitis, again the query is, are you saying pancolitis? So why do you mean partial thickness? Pancolitis simply means starting of the colon to end of the colon. So this disease will involve only the colon. And the most common site that is involved in this case is the rectum. Remember when I was teaching you Crohn's disease, if you're paying attention, you would have noticed that in Crohn's disease, the site that is spared is the rectum, but in ulcerative colitis, the commonest site that is involved happens to be the rectum. Now, once these ulcers will develop and will progress subsequently, the clinical profile of these patients will be that of painless bloody diarrhea. The person will say that I have to always be near the washroom. I have to go to the washroom 10 to 15 times per day. That is almost once every 1 hour. So he says, I've never taken a holiday for so many years because every time I'm having this discomfort when I go to the washroom, it's not the fecal matter that comes. It's mainly blood and a bit of mucus. Painless bloody diarrhea, and the frequency can increase even further also. I mean, this is pretty disabling, debilitating in a sense that even going out for a holiday, going out for a vacation is not possible because he needs to be having a washroom access all the time. And when you're traveling outside, sometimes washroom access may not be available. Painless bloody diarrhea is the usual profile of these patients, unlike Crohn's disease where I was explaining colicky pain. Do remember the fact that because substantial amount of blood is going to be lost here, these patients can even develop anemia. They can be even having loss of albumin along with blood proteins will also be lost. So ulcerative colitis is also a very peculiar terminology because When you say the word ulcerative colitis, the impression is that, okay, there is ulcer formation, but these ulcers bleed to the level that they even can cause hypoalbuminemia. Well, in a multiple choice question, because he knows that you will pick up the word protein losing enteropathy, he might just say that this person who's having this bloody diarrhea for, let me say, recurrent basis for last 6 months is having puffy eyes or is having pedal edema, because if the oncotic pressure will decrease, it might cause puffiness of the eyes, it might cause a pedal edema manifestation. There is a distinct possibility that transverse colons once again will be hampered in this patient. The motility part is hampered, so toxic megacolon will occur. Toxic megacolon is said to be present when the large bubble loop diameter is more than 6 centimeter. Incidence-wise, remember the fact that toxic megacolon is more common in ulcerative colitis as compared to Crohn's. When it comes to malignancy, though both Crohn's as well as ulcerative colitis are pre-malignant conditions, in the current edition of Harrison, the 20th one, it is mentioned that the incidence of cancer is equal in both Crohn's as well as ulcerative colitis. When I was a student at your age, I was taught that the incidence of cancer is more in ulcerative colitis, but in the current edition of the textbook, it is categorically mentioned, at least in the 20th edition of Harrison, that the malignancy risk is equal for both of them. So toxic megacolon is more in UC standard data, but cancer incidence is given to be equal, and most patients are going to come to you with a pedal edema, periorbital edema, and blood loss. Now, for the workup of this particular person, the first investigation I'm going to run is a P-ANCA. We read about P-ANCA in multiple other conditions. So while I'm jotting this down, please just recall where have you studied P-ANCA or what are the other disorders where you read about it. You read about it in GI, that is primary sclerosing cholangitis or hepatobiliary, then MPA, that is microscopic polyangiitis, and the current topic ulcerative colitis, where the high incidence of association is seen. Then subsequently I would like to confirm my diagnosis by going in for colonoscopy with a biopsy. On a colonoscopy or a proctoscopy, I will be able to see the proctitis component. In fact, in some of these patients, the rectal mucosa can be extremely friable, that even if you do a perrectal examination, when you withdraw your gloved finger, there would be blood on the gloved finger. So proctitis is one of the gross disability that is present in this condition. With biopsy, the findings are gonna be that granulomas are absent. I have already highlighted to you that if the question says granulomatous colitis, it is Crohn's. If it says non-granulomatous colitis, it is ulcerative colitis. And well, I also want to rule out possibility of a malignancy. If a person is not willing for a invasive investigation, I can make him drink contrast and I can go for a CT enterography, which is a very attractive way for evaluating these patients. You see, the best method would be to send in a camera, demonstrate the proctitis component. He says, no, I'm not interested. Then a CT enterography can be done. Apart from this, classically, barium enema findings are also asked. As you can see on the board, barium enema finding related to the colon can be seen here, which is called as pipe stem colon. In one of the earlier slides that I had shown to you, I had shown a very classical slide for Crohn's disease, where you will be able to see not one, but multiple sites of strictures present. So that is a very classical feature that you see with Crohn's disease. This image is gonna be demonstrating presence of multiple strictures on subsequent contrast-based studies in this person, where oral contrast has been given. But if you scan the current image on the monitor at the moment, you will notice that there is loss of posturations. In barium enema, if the MCQ says what is the earliest manifestation, mark my words there. If the question says barium enema, what is the earliest finding, don't straight away say a pipe stem colon will develop in a person, because that takes time to develop. The initial manifestation will be answered by you in the exam as granular appearance. Why that granular appearance is there is because of the development of those pseudopolyps. So when the contrast will flow over those pseudopolyps, it can give this appearance referred as granular. The disease progresses from inside to outside. So loss of hostrations is not a early feature, because hostrations are on the outside, no? So it is gonna be later feature. Earlier there's gonna be a granular appearance, then as the disease goes outwards, loss of hostrations. It is subsequently that you will use the term pipe stem colon. The data has been given both in the order of importance as well as how the manifestations will progress over time. The fifth investigation is very important because we are always interested in non-invasive tests for our patients. This was also a question that was asked in the NEET PG exam, that how would you differentiate between a diarrhea of inflammatory bowel disease versus diarrhea of irritable bowel syndrome. Irritable bowel syndrome is a separate lecture that I've taken subsequently. The feature that you read both with irritable bowel syndrome as well as inflammatory bowel disease. In inflammatory bowel disease in Crohn's, I was specifically talking about a bile acid diarrhea, and in this case, anyway, the colon is involved. One of the functions of the colon is absorption of water. So anyway, the fecal matter can be having a loose consistency, which the patient will cause the diarrhea. The test that you will do in this patient will be called as fecal calprotectin levels. So do remember this multiple choice question. Fecal calprotectin levels can help you differentiate between whether it is IBD versus irritable bowel syndrome. And anyway, in inflammatory bowel syndrome, you will be having blood, but in irritable bowel syndrome, IBS, irritable bowel syndrome, you will never be having blood in the stool. I mean, whenever you read blood in the stool, it can never ever be IBS. In IBS, abdominal pain is there, diarrhea is there, constipation is there. He'll go to washroom and he will feel better. But in this case, whether he goes to the washroom or not, the condition will still be the same, or rather, I would say after a few hours, the condition will again come back to the same status quo. He again has this feeling that he needs to use the washroom. Again, it is only blood and little bit of mucus and a little bit of fecal matter, or hardly any fecal matter that is being passed out. Once you get the workup of these patients fine, I just want you to scan these images. You can definitely notice a very characteristic loss of hostrations that is developing in this person. The term used is pipe stem colon. And in the second image, you can notice these dilated bowel loops. No, that is secondary to the megacolon that is occurring in this person. Do remember that for diagnosis of intestinal obstruction, if the small bowel loops are more than 3 cm, large bowel loops are more than 6 cm, and cecum more than 9 cm, it indicates there is some problem, right? If you find dilated loops, either it could be ileus or it could be intestinal obstruction. So just remember the rule 369, that is small bowel loop more than 3 cm, large bowel loop more than 6 cm, cecum more than 9 cm, 369 cm, that 369 rule that you need to remember. It basically tells you that there is a pathology which is contributing to proximal part of the gut to dilate. Now, once we have diagnosed ulcerative colitis, which I personally feel is relatively easier to identify, we'll come to the treatment of this condition. The drug of choice is going to be answered as standard sulfasalazine. However, he tried to modulate the question. Instead of asking you DUC for ulcerative colitis, he described a medical student who has been diagnosed with ulcerative colitis, and he says that this young doctor came to you. He said, when my exams come closer, I tend to feel nervous. That's obviously normal for anybody, but here the disease tends to worsen. You see, Ulcerative colitis and Crohn's disease severity can vary with time. The inflammatory cytokine levels can vary with time. So the question says there's an exacerbation to the level that every half an hour he's having to go to the washroom, blood is coming, so he's feeling so weak, he's feeling so tired. What you can do for proctitis component here is start this person on budesonide enema. I'm not saying that budesonide enema cannot be given routinely, but you see, giving enema regularly is not something which anybody would be very comfortable with. So it is to be used when a person is willing to take it. Otherwise, most patients tend to be preferring oral medications. Though personally, if I have to give to this person a rectal preparation, I'll be happier. But then you can understand from the patient's perspective, inserting something per anus on a daily basis, on a recurrent basis, is something that nobody would be very, very comfortable with. Other molecules like azathioprine are definitely useful, and even infliximab, we can step up the treatment depending on the severity. He says you have to increase the immunomodulatory drugs in this condition. You have to step up and step down the treatment depending on the disease course. So infliximab, which is a tumor necrosis factor alpha antagonist, can also be useful in this patient. Indications for surgery in cases of ulcerative colitis is to be read by yourself from surgery textbook or two before you. One of the important indications for surgery would be toxic megacolon. That's pretty understandable. The gut motility is gone, so there would be gross abdominal distension developing proximal. Apart from this, also remember that if the rectal mucosa is very friable, you see, I have already given steroid enemas to this person for last 1 month. I've even given infliximab. I've stepped up to azathioprine, then even used infliximab. I have tried everything that I have, every drug that I have, but still the rectal mucosa is friable to the level that it bleeds on touch. You see, I did a rectal examination of this person. When I withdrew my finger, the gloved finger was soaked with blood. I mean, that friable the gut mucosa is that you touching it, normally you would have done a PR so many times in your patients. I mean, you don't have blood coming up on the index finger, the gloved finger. But in this case, there's gonna be a friable mucosa that can even, it can perforate anytime, in fact. So that is where, the surgeon's roles comes in. So for ulcerative colitis, you definitely can read the indications for ulcerative colitis where surgery is to be done. But these are too pressing where, you press on the alarm button that right now we need to do something for this guy. That is surgical domain. If he just says what is the preferred surgery for these patients or surgery of choice for ulcerative colitis patients, I would like you to read up this topic from surgery also as I advised, but this is what is given in Harrison, proctocolectomy. Now, when you do a proctocolectomy, that's obviously the last resort because you tried everything and still the rectal mucosa can even be bleeding. Then I can just remove the rectum. But the patient will ask you, the relatives will ask you, sir, you're removing rectum, that is where the fecal matter will accumulate. Now, where will the fecal matter accumulate? So we are gonna be rather going in for creation of a reservoir for this person where the fecal matter can accumulate, that is ileal pouch anal anastomosis. So though the surgeon's words will be final for the surgery of choice for this condition, I've just quoted Harrison here. In Harrison, the surgery that is mentioned is proctocolectomy with IPAA, that is ileal pouch anal anastomosis, which is done in these patients. Lastly, I will be now explaining to you regarding the extra-intestinal manifestations of inflammatory bowel disease. Most of the things that I've said prior to this, you've read them even in pathology. So actually, most of the MCQs on this topic will be coming from this particular slide. If the question says overall, which is the number one extraintestinal manifestation encountered, it is arthritis, and he will even ask you which joints are involved. In fact, when you read it for first time, it looks very shocking that the migratory polyarthritis component that I have taught in rheumatic fever in cardiology can also be read by you in literature of inflammatory bowel disease. So the patient can be having involvement of the large joints, and the arthritis can jump from one joint to another, like ankle, then subsequently knee joint, maybe the elbow joint, not necessarily in that order, but the arthritis component can jump from one joint to another. Apart from this, a lot of these patients can be HLA-B27 positive. Now, you are all aware of the fact that HLA-B27 positivity is studied by you in ankylosing spondylitis, but I want you to remember that even in patients of IBD, you can be reading about low backache being complained by these patients, that is sacroiliitis. HLA-B27 positivity has been taught to you for ankylosing spondylitis. Then is psoriatic. I'll just use short forms here. AS is ankylosing spondylitis. PSA is psoriatic arthritis. Juvenile rheumatoid arthritis, not rheumatoid, but plain JRA, that is juvenile rheumatoid arthritis. Then is a Reiter syndrome, and then is inflammatory bowel disease. So these are conditions where you need to remember this is hardcore internal medicine data. HLA-B27 positivity is found in the following conditions, and in IBD, large joint involvement including low backache can be a presentation. Then you will read about hepatobiliary associations here. One of the important hepatobiliary manifestation is primary sclerosing cholangitis, and the incidence of this is more in ulcerative colitis as compared to Crohn's. So in the earlier part of the discussion, I was teaching you that it is toxic megacolon that is more common in ulcerative colitis. Now PSC has been added. Primary sclerosing cholangitis can be understood from this sketch that I'm making before you, though I have talked about this topic separately in the liver one also, but just pay attention to the details here. This is the gallbladder, the cystic duct, the common hepatic, and the left and the right hepatic ducts. The problem in this person is that due to P-ANCA antibody, remember P-ANCA was taught in ulcerative colitis and even now in PSA, there is going to be fibrosis, there is going to be narrowing of the extrahepatic biliary pathways. The blue is the representation of bile being produced in the biliary radicals. The red in this diagram uniformly highlights the fibrosis. I'm just putting numbers here to say that in primary sclerosing cholangitis, the name is sclerosing, that means fibrosis. The fibrosis starts from extrahepatic and go intrahepatic also, because there is obstruction to the flow of bile both in the liver as well as outside the liver. So there would be biliary stasis that would contribute to obstructive jaundice manifestations. So they can be fatigue, there can be pruritus, there can be mustard yellow urine in a person. The features of obstructive jaundice have been discussed in relevant section, that is specifically with respect to a patient who's having disorders like Dubin-Johnson, etc. in the medicine section of liver part. That OJ manifestations like pruritus can also be given in MCQ of inflammatory bowel disease. Then would be dermatological manifestations. One of the important ones that I want you to remember here is erythema nodosum. The last time I have taught about erythema nodosum is in rheumatology section with respect to sarcoidosis. The area where you will notice erythema nodosum developing will mostly be over the shin. Another medical disorder where you read about this is sarcoidosis. The next dermatological manifestation can appear over the shoulders of the patient, back of the neck. The name is very sweet. In fact, you call it sweet syndrome. But too much of sugar anytime is bad. So the term alternatively used here is febrile neutropenic dermatosis. Because of this peculiar terminology, the examiners would love to write not the word sweet syndrome because that's relatively easier for you to crack. It would be febrile neutropenic dermatitis, and the location of this lesion will be mainly on the back, mainly between the shoulders, on the shoulders, upper part of the trunk of this person. It would be reddish lesions associated with fever also. Other features that can develop is like clubbing. So clubbing can be seen with cirrhosis of liver. Clubbing can be seen even with GI manifestations like inflammatory bowel disease. In fact, these patients can be having tendency to develop osteoporosis. Then even dermatological manifestations can occur. Eye manifestations can occur in these patients like scleritis. So the point is that there is no point of trying to remember all of them, but at least the important ones that I'm highlighting should be given the due respect. Like arthritis part is quite extensively asked, and then is the hepatobiliary component. These are extra-intestinal manifestations of IBD, and they need to be given maximum importance in this discussion that I've had with you on this particular topic. To wind off, I would also like to summarize where have I said diseases which are more common in ulcerative colitis as compared to Crohn's, situation where incidence is equal, and condition where disease presentation is more in Crohn's as compared to ulcerative colitis. Remember the fact that incidence of toxic megacolon is more in ulcerative colitis than Crohn's. Primary sclerosing cholangitis follows suit. Equal incidence is for malignancy, which is also one of the leading causes of death of patients of inflammatory bowel disease. It's not infection, it is cancer that contributes to mortality. What is more common in Crohn's as compared to ulcerative colitis? So all the extra intestinal manifestations that I just explained to you, ranging from something like clubbing to manifestations of PSC or even arthritis component, extra intestinal manifestations are more common in Crohn's as compared to ulcerative colitis. All of these are epidemiological based facts, which is always a good idea to write it down, because the more you write it down, then there are three stimuli. The audio visual is already I'm providing you, but if you're trying to note with me at the same speed, you might miss out a few aspects. You don't need to note out every alphabet, but the point is that your writing speed also needs to develop over a period of time, so that you have a third input that is coming in, and the more you are aware of all these inputs, the audio visual and the writing part, then your accuracy, your speed will definitely start increasing. So you are all brilliant people. I don't need to tell you how to teach, but those tips, those tidbits that I keep on saying in between, if you just keep on adding them to your regimen, if you just keep on improvising on a daily basis, just do small parts on a regular basis, just read medicine in bits on a regular basis, and you will see that at the end of 2 months, 3 months subsequently, your knowledge will grow dramatically. You will be able to see the link between the various subjects. These are the details that I